Hello students and welcome back to my channel. Today we're going to continue the children nutrition series of videos and we're going to take a look at the integrated health disorders. So expect to learn about the heart disease, oncology and renal disease, as well as the inborn error of the metabolism and the ketogenic diet. Hi, I'm Tommy. I'm a human nutrition student and researcher at the university. What I do in this type of video is to synthesize my classes at the university so then I can explain and teach you the best and most valuable information you need to know. So let's begin this video by taking a look at the heart disease, oncology and renal disease. So the cardiopathies. We have to take into account the risk factors for malnutrition associated with heart disease, but also with digestive diseases and hypermetabolism and or nutrient wasting. The cardiopathies can be cyanogenic, having hypoxia problems, or non-cyanogenic, no hypoxia problem. The first thing to do is to correct the cardiac defect, and the second is to adequate the energy intake without increasing the water intake. It's very important, this thing. As always, we tend to prefer the oral way, then the supplements, if not the enteral, and as last one, the parenteral nutrition. Here we have the chylothorax and the mesenteric flow disturbances. The chylothorax is the accumulation of lymph in the pleural space. And here we have to use a monogen formula, which is low in long-chain triglycerides and high in MCT, medium-chain triglycerides. Because if we don't do this, we are not going to be able to absorb those fats. Because if we do, they are going to go to the pleural space. Because long-chain fatty acids that come from triglycerides, indeed, they go through the lymphatic system. The MCTs do not. They go straight to the bloodstream because their absorption is different. That's why we give a lot more importance to the MCTs here. On the other hand, in the mesenteric flow disturbances, there is an increased risk of malabsorption and nutrient loss. And here we have to use peptide formulas. So that means digested proteins. Moving on, taking a look at oncology, we have an anti-tumor treatment, macronutrient metabolism and hormonal disorders. The malnutrition has to do with infections, hospital stay, and muscle weakness. You have to know that the cancer can lead to anorexia, which is indeed malnutrition, then to asthenia, and ultimately cachexia. So it's very, very important to avoid this development and treat in an early stage. Nutritional assessment, the tumor type and size, using the ABCD, anthropometry, biochemistry, clinical, and diet. The most frequent is the leukemia, then the central nervous system tumors, and the Hodgkin's lymphoma. The general recommendations for cancer patients are a balanced and healthy diet, of course, high nutritional value, hydration, room temperature, and avoidance of strong odors. They are very uncomfortable for them. Adjust the diet according to the symptoms. So nausea and vomiting, do not eat large meals. If you have diarrhea, no fruit with skin. Dysgeusia, avoid meats because they have a metal-like flavor. Anorexia, do not take away the favorite foods on the day of the chemotherapy, for example. And the constipation, use fiber. And we also have to take in account mucositis. And then we have nephropathies. They are correlated with a severe decrease in growth hormone. The anthropometry is compared to a young children due to the small growth. So when we do the ABCD, we do not compare with the other children of the same age, but with children that are younger. The hormonal factors, the decreased intake, the inflammation and the acidosis are the reasons why there is a low weight, the drug toxicity, anemia, infections and other problems. The goal here is an adequate growth according to the renal function. It's very important. They have a problem in the kidneys. Water and electrolyte needs and adjusting water and electrolyte losses. So we have to do adjustments to get the right amounts. Dialysis and protein intake. We have to increase the protein intake, which is very counterintuitive, up to 8 to 14 grams per day to ensure the growth of the individual. These children have two options, either preserve the kidneys or ensure the growth. And it's way better to ensure the growth as you can then transplant another kidney in the future. We must give them 100% of the caloric intake they need. And here we also recommend a plant-based nutrition. The formulas with a calorie content are higher than the 0.7 kilocalories per milliliter, which is indeed the amount of calories in the breast milk, are considered hypercaloric. And we must consider using hypercaloric formulas in some individuals, as we must ensure growth with 100% of the caloric intake. So it's very important to give also micronutrients, but do not overdo them, as they have a kidney problem and they are not going to be able to metabolize all those minerals that we provide them. So as you can see, it's a very tricky situation, but the best thing we can do really is to ensure the growth of the child. And now it's time to take a look at the main inborn errors of metabolism. So these have to do with failures in enzymes or cofactors. The screening is done in most modern countries. And as the first one, we have the phenylketonuria. This is the failure in the conversion of phenylalanine to tyrosine. These are two amino acids. And it has an autosomal recessive inheritance. The symptoms: musty odor, seizures, skin rashes, and lighter skin and hair due to low melanin. And worst signs and symptoms are microcephaly, a small head volume, hyperactivity, mental retardation, and paranoia. Dietary treatment goals is to prevent neurological damage, a permanent adherence to a low phenylalanine diet, and to maintain the plasma phenylalanine, because we still need it for growth and development, and also for the mental function. We have to provide a complete nutritional diet as well. Here we are talking about children, and they are in a growth state. So we have to give this essential amino acid, but not in too many quantities. So the initial management is with breastfeeding or formulas. In breastfeeding, 5 doses per day, 15 milliliters of phenylalanine-free formula, and then breastfeeding on demand without limit. So doing it this way, we make sure that part of the phenylalanine of the diet is limited. Using formulas, we have to put 200 milligrams of phenylalanine a day. This is 60 to 70 milligrams per kilogram per day. And we do that with a Formula 1. And we have to adjust the quantities according to individual tolerance. And the rest of the phenylalanine-free formula upon request. So basically, after we reach that 200 milligrams, we stop completely and we go phenylalanine-free. The subsequent management is to monitor the phenylalanine levels. But not only that, we have to do the ABCD, anthropometry, biochemistry, clinical, and diet evaluation. The introduction of solid foods, similar to the diet, but restricting natural protein. These are, for example, meats. And we have to follow the food groups. There are certain food groups that we must avoid or limit, again, animal proteins. And there are commercial formulas of amino acids free of phenylalanine that we can take in account. Another type of error are the errors in the urea cycle. These can lead to a respiratory alkalosis due to hyperventilation. Here we have a hyperammonemia, and we have to limit the protein intake, increase the anabolism, and limit the intestinal ammoniagenesis. There is a specific amino acid deficiency, and we have to supplement with citrulline and arginine. Here we have a substance depletion, and we have to contribute with carnitine, citrate, and glycine. So as you can see, a lot of amino acids are involved because the urea cycle cleans the body from the waste products of amino acid metabolism. And when there is a glutamine transporter saturation, we have to limit the protein intake and stimulate the urea-like products. We have to monitor the levels, and there is an elevated chromate excretion. The limitation of nitrogen supply. So if extreme, there is a decompensation, and we do not want that. So we have to reach a maximum tolerance dose, which is individual to every child. We must give a caloric supplement and prioritize the proteins with a high biological value. The side effects of limiting proteins are vitamin deficiencies, trace elements, and long-chain fatty acids deficiency, indeed. We can make use of specific commercial preparations to guarantee the minimum amounts of micronutrients. The protein needs in this pathology are from 0 to 4 months, 1.6 grams per kilogram per day, from 5 to 12, 1.4, and from 13 to 36 months, 1.2, to then go to 1 gram from 4 to 10 years. So as we grow, we lower the number from 1.6 to 1. We have to limit the intestinal ammoniagenesis, and it depends on the substrate and the number of bacterial colonies. and we have to avoid the constipation. To do that, we provide high fiber. The use of lactulose in acute decompensation will stop the colonization, which is then beneficial for the intestinal ammoniogenesis limit. So we saw that we need to maintain proteins for a good anabolism, but we also must avoid catabolism, acute decompensation. We have to give enough glucose and fats, because lower glucose will lead to higher gluconeogenesis. From where? From proteins, from the muscle. So we must promote anabolism. We have to reach the minimum protein for the age and weight, with ammonia within the normal limits. Here, we have to increase the caloric intake. There is an analytical control, the measurement of rapid turnover proteins, such as prealbumin and the retinol binding protein, avoiding the albumin because it's not a rapid turnover protein. And then we have to divide the daily nitrogen intake to avoid sudden fluctuations. So it's better to have smaller doses multiple times in a day. And another thing we have to do is to stimulate the elimination of urea-like products. This is using citrulline and arginine. We have to administer arginine first, always. And we have to provide carnitine as well in acute crisis and in diets that limit proteins of high biological value. Glycine is necessary to monitor for possible chelation, and we have to provide citrate if there is an aspartate depletion. And then we have organic acidemias. So these are several diseases in which is involved the metabolism of essential amino acids. And we have to wait more than 24 hours to do an analysis after eating, because there can be problems even with a screening. They all produce metabolic acidosis, and the ones we are going to see also cause ketoacidosis. So basically here, what we are saying is that once the child is born, we have to wait until he or she eats for the first time, because the main problem is with the metabolism of essential amino acids. So the two main ones we have are the propionic acidemia and the methylmalonic acidemia. They both are related to a failure in the enzyme or cofactor. And the propionic one is cured by providing biotin, whereas the methylmalonic is cured by providing vitamin B12. The clinical forms in the neonatal is severe hyperammonemia and make a differential diagnosis to actually check which one is causing it. And in the late one, it can be acute recurrent, intermediate, or chronic progressive. Symptomatology: the chronic tendency to metabolic acidosis, neutropenia, hyperanemia, and ask about the family history. Very important. The neonatal onset: the child is born normal, but goes into a coma after starting to eat due to the proteins, to the amino acid. And there is refusal of feedings, vomiting, and etc. On the late onset, there is only a refuse of feedings, vomiting, coma, infections, but not a coma straight after being born. The symptoms are depending on the deficiency and enzymatic cofactors. And there is an accumulation of glycine that acts as a toxic agent, and the carnitine must be administered to counteract this. The complications: well, of course, malnutrition and nutritional deficits. And we have to provide an enteral nutrition to try to correct this. And this disease entered screening in 2022. So it's very, very recent. The dietary treatment is when it's clinically ill, enterally via nasogastric tube, or directly parenterally in case there is, for example, vomiting. And when there is vomiting, we have to treat it as an acute poisoning. We have to avoid substrate production through protein restriction. So zero proteins. We have to try multi-coenzyme therapy, providing vitamin B1, B12, and biotin. An adequate caloric intake, provide carbohydrates over lipids. We have to cure the acidosis and consequent hypoglycemia. We have to limit the protein intake at 0.75 milligrams per kilogram per day. As you can see, is very low for a child. The tolerance ceiling is measured according to the levels of acidosis and ketone bodies. This is very important to remember. And the adjuvant measures are high calories, high biological value proteins, and measuring the prealbumin and the retinol binding protein, so fast turnover protein. Albumin is not useful because it's replaced more slowly. And we have to be careful with branched chain amino acids. And we have to limit leucine as it can create more toxic metabolites. This is most important in the first stages of life. The clinical practice: there are tables that classify amino acids according to their necessary quantities and to the pathology. Once you reach the limit of restricted amino acids, you must supplement with foods free of those restricted amino acids. and a limited supply of isoleucine is required to avoid the enteropathic acrodermatitis. And here we have different special products. Those ones free of the branched chain amino acids, those free of isoleucine, valine, methionine, and threonine. The ones that are incomplete proteins is only used when very low maximum limit of proteins in a day. And also the leucine-free formulas. We have to supplement with foods that contain proteins of high biological value to maintain anabolism. The essential amino acids are required to ensure a very high biological value and digestibility. And the cofactors we can provide are the vitamin B1, the vitamin B12 in the methylmalonic acidosis, and the biotin in the propionic acidosis. And we also have to provide micronutrients with monitoring of analytical values. And then last but not least, we have the ketogenic diet. So this started as a treatment for epilepsy by fasting with Hippocrates. So basically, Hippocrates saw that if we treated epilepsy with fasting, it improved. And this diet, what it does is simulating fasting. The diet consists on high fats, low carbs, and moderate proteins. It's basically an anabolic state in a fasting state. It does not restrict calories, but changes only the proportion of macronutrients. Instead of using glucose, fatty acids and ketone bodies are used for energy. The MCT, the medium chain triglycerides, pass directly through the intestine. And these are very interesting to use because they are going to create a lot more energy more quickly. The mechanism of action improves adaptation to the disease. It increases the GABA neurotransmitter, it lowers the glutamate, and it changes the intestinal microbiota. The types of diets, the fat carbohydrates plus protein ratio. So basically here we have the classic, which is 4:1 or 3:1, which has 90% of fat, and it may have side effects. 4:1 means that we have 4 parts of fat per 1 part of carbohydrates and proteins together. The MCT combined, as you can see, MCT are very important because you have to know that higher MCT percentage in the diet will lead to higher ketosis. Then we have the modified Atkins, which is limiting 10 to 30 grams of carbohydrates per day, and the rest is free. It's up to you how you want to divide your proteins and fats. And then we have also the low glycemic index diet, which is limiting the carbohydrates from 40 to 60 grams of carbs, but all of them must be very low glycemic index. The common characteristics of all these types of ketogenic diets are high fat content and low carbohydrate. The problems are that high fats can give cardiovascular risk, and low carb can give low vitamins and low fiber. So as you can see, these diets are mostly fat, but not all fat is the same. So they started to create the Mediterranean ketogenic diet pyramid, and the purpose was to improve the fat quality. You have to know that the ketogenic diets are of choice in metabolic diseases, such as the GLUT1 deficiency. This is the glucose transporter to get glucose into the brain, and in the pyruvate dehydrogenase deficiency as well, which is the inability to create acetyl-CoA from pyruvate, from glycolysis indeed. And they are also used in the refractory epilepsy syndromes, when there is a drug resistance. As these diets are becoming more and more popular nowadays, they are starting to do trials in autistic people, migraines, brain tumors, Alzheimer's, and even Parkinson's. Diet effectiveness. So when talking about the epilepsy, when the number of seizures decreases by 50% in 1 month, we consider effective, but it must be maintained for 2 to 3 months for the evaluation. And also when there is a cognitive and behavioral improvement, we can say that the diet was effective. We have to discontinue gradually after 2 years in epileptic syndrome, but we have to continue using that diet in the GLUT1 deficiency and the pyruvate dehydrogenase deficiency. When the child is small, we have to start with the classic one, and as he or she grows, we have to switch to the modified Atkins. This is more sustainable for the long term, and in cases of repeated convulsions, it is administered through a nasogastric tube using formulas. The ketosis goals. So ketosis bodies between 2 and 5 millimoles per liter, and you have to know that more ketosis does not mean more effectiveness. The controls of ketosis are done before dinner because it's lower in the morning because of cortisol, acetoacetate in the urine, and beta-hydroxybutyrate in the blood. These two are measured for the disease control, indeed. The contraindications of the ketogenic diet are for diseases that have compromised fat metabolism or when there is a high glucose requirement. The adverse effects of keto diets are hypoglycemia, which we can correct giving 2 to 4 grams of glucose, hyperketosis, when we get over 5 millimoles per liter, and also dehydration. So water is lost through lower glucose in our body because glucose contains water. Other types of adverse effects are the dyslipidemia in the 60% of the cases. It will increase the LDL, gastrointestinal, giving nausea, vomits, and abdominal distension, as well as constipation. And the nephrolithiasis. Being acidic, it favors the creation of oxalate and uric stones, so kidney stones. And in some individuals, it can also give a stunted growth with a lower bone mass. And it also gives lower nutrients, such as vitamin D, calcium, phosphorus, selenium, magnesium, and carnitine. So as a conclusion, the ketogenic diet is a therapeutic diet. The factors of choosing the type of the diet are the underlying disease and the age test interval. And the ketosis intensity does not relate to the effectiveness. Okay, this is it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Don't forget to like, subscribe, and turn on the notifications so you get notified every time I upload a new video. If you find value in this, please share it to your friends and family to spread this knowledge to them as well. Thank you so much for watching, and I will see you in the next one. Hope you enjoy it. Ciao!